Hello, everyone. Welcome to Noble Psychiatric Services presentation. I'm Dr. Ondieki, one of the guys behind Noble Psychiatry and Noble Pathway, and I'm excited to welcome you to this presentation. I want to begin with one question. What happens when mental health challenges go unnoticed, misunderstood, or untreated? Every day we have individuals silently struggling with depression, anxiety, trauma, suicidality, and other psychiatric conditions that affect not only their mental health, but their families, relationships, and the quality of life. This is why this conversation is important. Today, we'll explore substance use disorders in a practical, evidence-based, and clinical relevant way aimed at improving patient care and strengthening our approaches as mental health professionals. Thank you for being here, and we will get started. This presentation is produced and designed by the Noble Psychiatric Services. Substance use disorder, attained as SUD, are described in this presentation as long-term recurrent brain abnormalities that occur concurrent with mental health issues. Trainees will investigate how addiction neurologically, psychologically, and social components interact to create a complicated clinical picture known as the dual diagnosis. The session emphasizes that integrated stigma-free management rather than abstinence alone forms the basis of efficient, compassionate care, drawing on modern framework from the DSM-5 and also the SAMHSA, which is a substance use website. With focus on patient involvement and safety, participants will look at how harm reduction concept might be used to close the gap between acute symptoms management as long as long-term rehabilitation. The epidemiology and the clinical significance. A significant cost on public health is shown in epidemiology of substance use disorders. In the United States, 40 to 60% of individuals will have a concurring psychiatric disorder such as MDD, bipolar, PTSD, or personality disorders, and 1 in 5 will satisfy the criteria for substance use disorder at some point in their life. The population with dual diagnosis is especially susceptible to higher rates of morbidity and mortality, including infection complication, overdose, and suicide. Trainees will look at how this cycle is sustained by trauma, socioeconomics, disparities, and lack of integrated services. Recognizing this trend places addiction in the context of preventable and treatable illnesses that calls for interdisciplinary care rather than a moral failing. We look further into the addiction model. According to the contemporary theory, addiction is a chronic brain illness characterized by maladaptive alterations in reward, motivation, and memory circuits. The neurological foundations of these processes will be reviewed by the trainees with a focus on glutamatergic plasticity, dopaminergic signaling in the mesolimbic pathway, and the dysregulation of the stress response system mediated by the corticotrophin releasing factor. Despite negative outcome, this neuroadaptive leads to obsessive substance seeking behaviors. From a biopsychosocial standpoint, environmental stresses like traumas and genetic predisposition all have an impact on addiction. This concept emphasizes that relapse is part of the illness trajectory rather than personal failure, reframing addiction as a disorder requiring long-term management techniques similar to diabetes or hypertension. The diagnostic framework, as far as the DSM-5 framework for diagnosing substance use disorder, which views addiction as a continuum of severity rather than a categorical state, is described in this slide. Meeting 2 or more of the 11 criteria in 4 domains: risky use, impaired control, social impairment and pharmacological effect, tolerance and withdrawal, is necessary for the diagnosis. The 3 severity levels, mild 2 to 3 or moderate 4 to 5, and severity 6 plus, help adjust the level of intervention. Since alcohol, opioids, stimulants, cannabis, and sedative have different clinical presentations and treatment, it is crucial to identify the particular chemical class. Screening instruments like Audit-C, CAGE, DAS-10, and ASSIST offer methodological approaches to identify risk and direct additional evaluation. They should be used in the trauma-informed, non-judgmental way to encourage trust and disclosure. Family input, toxicology screens, and laboratory tests like liver function tests and drug screens are examples of collateral data that enhance diagnostic accuracy and facilitates continuous monitoring. By monitoring the endurance of symptoms during sobriety, clinicians must differentiate between substance-induced symptoms and fundamental psychiatric problems. As far as dual diagnosis, the reciprocal relationship between substance use and mental illness is examined in this section. Substance use frequently precedes psychiatric conditions like depression, anxiety, and PTSD as people try to self-medicate and medicate uncomfortable symptoms. On the other hand, long-term drug use can cause or worsen mental illness by interfering with the neurochemical processes. By evaluating symptoms persistence following a period of abstinence, usually 2 to 4 weeks, and by looking at temporal patterns of onset, trainees will learn to distinguish between substance-induced and primary psychiatric diseases. The debate highlights the need for concurrent management options by pointing out that individuals with dual diagnosis have higher recurrent rates and worse outcome if either ailment is treated separately. We continue on that. Overlapping neurobiological vulnerabilities affect the reward and stress system, give rise to dual diagnosis. The lesson will go over how hyperactivity of the HPA axis increases anxiety, desires, and the mood instability, while dysregulated dopamine transmission in the mesocorticolimbic pathway contribute to reduce reward sensitivity. Shared variations such as the DR2 as well as a commit as well as a 5-HTT-LPR polymorphism that predisposed people to both psychiatric and addictive traits have been found in genetic investigations. Through epigenetic pathway, environmental factors include social isolation and traumatic childhood experiences further interact with these vulnerabilities. Clinically, these findings guide individuals' therapy plans and focus on cognitive control, emotional resilience, and neurobiological stress management. As far as the integrated model, we will go ahead and examine 3 main care models: sequential and parallel, as well as integrated treatment. Relapse during untreated phase is a common reason why sequential approaches treating one disorder before the other one fail. Results from parallel care are dispersed because it offers concurrent but disorganized management. The APA and the SAMHSA support the integrated model, which addresses both conditions simultaneously in a single cooperative framework. Motivational interviewing, cognitive behavioral techniques, medication, and case management are all used in an integrated program under single clinical supervision. These paradigms show better results in symptoms reduction, treatment adherence, and functional recovery, underscoring the significance of system-level cooperation between primary care, addiction medicine, as well as psychiatry. As far as the pharmacological approach, evidence-based drugs specifically to substance use and mental health comorbidities are part of the pharmacological component of integrated therapy. First-line treatment for alcohol use disorder include naltrexone and acamprosate. Disulfiram is only used in certain situations. The 3 main medications used to treat opioid use disorders, buprenorphine, methadone, and extended-release naltrexone, each lowers mortality by over 50%. Although off-label drugs like topiramate and bupropion may provide supplemental advantages, behavioral treatment are the main treatment for stimulants and cannabis use disorder. The safe co-administration of antidepressants, mood stabilizers, and antipsychotics in dual diagnosis situations will also be covered by the trainees, with special attention paid to the drug interactions and the possibility of sedation as well as drugs abuse. When we think about harm reduction, meeting patients where they are and putting safety and participants ahead of quick abstinence are key components of the harm reduction paradigm. This section looks at the fundamental interventions such as medication-assisted treatments, supervised consumption places, naloxone distribution, and syringe exchanges in initiatives. These taxes clearly lower overdose mortality, HIV or HCV transmission, and use of emergent medical services. The ethical underpinning of harm reduction, autonomy, compassion, and social justice, as well as how this strategy promotes trust and sustained involvement, will be discussed with the trainees as well. Safer prescription procedures, emergency management, and quick motivational interviewing that lessen harms while fostering change, readiness are examples of practical applications. When we talk about motivational interviewing, a cooperative, goal-oriented communication approach that boosts a person's own drive for change is called motivation interviewing, or MI. Along with the stage of development in the trans-theoretical model, trainees will learn about OR's framework, which consists of open questions, affirmations, reflections, and summaries. The program will use case conversations to show how MI helps patients overcome ambivalence by exposing difference between present behaviors and long-term values and validating resistance. MI increases retention and treatment success rates across substance use disorder population by empowering the patients to express their own motivations for change rather than prescribing fixes. As far as risk management, safety management in dual diagnosis care goes beyond acute crisis. Clinicians must routinely check for suicide risk, probable overdose, and dangerous prescription combinations such as benzodiazepines and opioids. Urine drug screen, prescription monitoring through the PDMP program, and adherence checks are essentials. Trainees need to learn to balance patients' autonomy with supervision, monitoring, stress, open communication, as well as collaboration and safety planning. Coordination with addiction treatment, social support, and family participation improves accountability while sustaining the therapeutic partnerships. Recovery-oriented model. The recovery-oriented care defines treatment and success beyond abstinence by stressing functional progress, personal purpose, and social integration. Trainees look at the framework like peer support, group therapy, and recovery coaching as important components of long-term stability. See cognitive behavioral relapse prevention and mindful-based therapies assist patients in developing coping mechanisms against the triggers. Clinicians need to assist the patient define the recovery on their own terms by emphasizing empowerment, hope, and autonomy. As far as we come to a conclusion, substance use disorders are inextricably linked to physical disease. Dual diagnosis is more than a norm than exception. Effective care necessitates integrative, trauma-informed, and non-stigmatized approach that links psychiatry and addiction medicine. Harm reduction and motivational interviewing are effective strategies for engagement and safety, but recovery-oriented framework promote long-term wellness. Trainees are taught to see each patient interaction as a chance to build trust, prevent damage, and empower individuals to pursue self-directed recovery. And that concludes this presentation for addiction. With that, if you have any questions or concerns, you are free to send us an email or leave us a comment, and we will be glad to follow up with you. From Noble Psychiatric Services, we wish you nothing but the best.